The guidelines changed, and Pedro tells me they changed this morning, so I didn't quite get mine up to date. But I think the bottom line is all of the guidelines now are recommending integrase inhibitors as first-line therapy. In those countries that have lots of resources, they have now eliminated the integrase inhibitors that require boosting as their preferred integrase, so they're preferring the unboosted integrase, which are now dolutegravir and bictegravir, together with the backbone of your choice. And up until very recently, there have never been any gender-specific guidelines. And it's taken a tragedy in order for us to try and finally include women in our treatment guidelines, which of course we should have done a long time ago. So are integrase inhibitors the optimal choice for women? And of course, all of the pivotal trials that we see of almost every antiretroviral drug since the beginning has been conducted primarily in gay white men. For the last decade or so, many of us have challenged the pharmaceutical companies and challenged the journals to ensure that at least gender-specific analysis of these studies get done. But even under those circumstances, there's never enough women in the study to power it for women. So finally, the pharma is starting to listen, and they now have been conducting a number of women-specific only studies. So that's great. So we really don't care which drug women take relative to men, but really what's important is which drug is best for women. So these women-specific trials do allow us to compare regimen A to regimen B to see if one of them is better tolerated or works better in that sex. And so the first study that became available was a study called WAVES. And WAVES started out using Stribild, which contains Levetagravir boosted with cobicistat, tenofovir, and emtricitabine. And it compared it to atazanavir boosted by ritonavir. So, of course, one of the problems is it the right comparator? Because who is using boosted atazanavir in their women at this time? But the problem was it's when this trial was designed and safety of drugs in pregnancy was a concern. And at the time this study was designed, the protease inhibitors were considered to be the drug of choice for women who were pregnant. And they wanted to ensure that if women became pregnant over the course of the trial, that everything would be fine. So that's why atazanavir was chosen as the comparator. Once WAVES sort of got to the end, they changed the name, and they now made the study called OLE. And basically what they did is re-randomized women. And so now, rather than Stribild, they then went to Genvoya, which of course contains the tenofovir alafenamide instead of tenofovir, and again showed that either Genvoya or Stribild were better than boosted atazanavir, and the better was not in terms of virologic efficacy, but really improved tolerability. And the major tolerability factor that was driving this was the jaundice. And as we know that many women who do take atazanavir will have that problem, and so that was the key factor that was driving the better outcome of this drug. However, when they went on to OLE and then did incorporate studies of bone mineral density in kidney, these improved with the switch from tenofovir to tenofovir alafenamide, much as we had seen in gay men. But again, the caution is that most of these studies were done in young women. And of course, the women who are going to have the biggest problems with their kidneys and bone mineral densities are those who are aging and approaching the menopause. And the number of women in the studies in that age group was small. And then the second major women-only study was called AREA, and AREA in this time looked at Triumec, which was the combination of dolutegravir with abacavir and 3-TC. Again, for the same reasons, atazanavir was chosen as the comparator. And again, there was an improvement in terms of tolerability with the Triumec, but with no issues related to toxicity. So most of the differences related to that or drug discontinuations for those other administrative reasons. There was huge viral suppression in all of these studies, and there was no emergence to resistance to anything except one patient on an atazanavir-based regimen developed a 184V mutation. All of the rest in the women, so we're talking, over 1,500 women, no resistance happened. So resistance seemed to occur less frequently in the women in these trials than in the comparative studies in the men. So what about older, and we'll say both men and women? And I think much of what you've seen today would argue that integrase inhibitors are an optimal choice. There are fewer drug-drug interactions with the integrase inhibitors. There are fewer metabolic issues, particularly as it pertains to lipids. And as both women and men age and start to develop more comorbidities, you have less additive toxicity to those comorbidities, such as depression, heart disease, bone disease. And for women, this is particularly crucial as they transit through the menopause and they lose their own estrogen protection against coronary artery disease and osteoporosis. The other reason why integrase inhibitors are an optimal choice as people age is for everyone. As you age, renal function does start to deteriorate, and these drugs do appear to be safe in deterioration of renal function. We know that people aging in general and aging with HIV are more likely to be on treatment for comorbidity conditions. This was a study that was performed out of our clinic by our clinic pharmacist, Dr. Alice Singh, who was looking at, does this work? No, only Jose can make it work. Yeah, so looking at individuals less than 50 years of age versus those who are greater than 50 years of age. And if we look at all of the different types of medications that individuals might take for comorbid conditions, in every circumstance, they were much more likely to occur in people who were older than 50 years. And why is that important? Well, polypharmacy has been linked to a lot of bad outcomes. And one of the particular bad outcomes that it's been related to is falling. And so this, again, was a single cohort study of close to 400 individuals advancing in age with HIV and looking at those individuals who'd had a fall. And it was found that fall risk increased with comorbidity with an odds ratio of almost 2. And falls increased with medication for comorbidity with a hazard ratio of about 1.5. So being on more drugs is sort of, I guess, a marker of perhaps being more frail, perhaps having more falls. And if you have more falls, you're going to have more fractures, and round the comorbidity circle goes. We also alluded to the fact that bone mineral density does deteriorate with age. And so that may be a time that we really need to consider the drugs in person's antiretroviral regime, and again, mainly women as they transit through the menopause. And so this was data from the ACTG trial, which did compare either boosted atazanavir or boosted darunavir to Reltegravir on a backbone of reverse transcriptase inhibitors. And as you can see, the changes in bone mineral density were lower in those individuals receiving Reltegravir than those who were receiving any of the protease inhibitors. At the moment, we are conducting a clinical trial which we have called BEING. This is a study in perimenopausal women, so we're taking women between the ages of 45 and 55 and doing these similar switches in their backbone regimen to see what impact we can have on bone mineral density, because we really do not know in those women aging and transiting through the menopause whether this is a particular time of very high risk for those changes to occur. So we'll let you know when we're finished with that. You've heard stuff from the SWORD study a couple of times already today, and again, just the bottom line is by switching away from the backbone and primarily from switching away from the tenofovir, we have seen changes in improvements in bone biomarkers, lipid biomarkers, and renal biomarkers. And I think that's all good. And if everything were equal at the end of the day, then it makes sense that everybody should be off these agents. But of course, we need to caution ourselves and to remember that a lot of these changes that we're looking at in these studies reflect changes in biomarkers. And we really, truly do not know what the clinical significance of these are, whether changes in bone mineral density in young gay men actually translate into fractures. We don't know if changes in renal biomarkers end up in more people ending up on dialysis. There really is some missing information for us to make these decisions. And this morning again, you also showed the switch from those on protease inhibitors to delegates, particularly those with high cardiovascular risk, no impact on their virologic outcomes, but improving many of their lipid parameters. So I think I'm just trying to argue the case that often we get patients on stable regimes, everything's going well, and as Pedro alluded to, if it ain't broke, don't fix it. But perhaps as people are getting older, we need to think about some of the things that may get broke and whether or not we should adjust our antiretroviral therapy so that we do not add to those problems. The other advantage of the integrase inhibitors as we age is drug levels do not seem to change with deterioration of renal function. And this was a study that was done by Angela Kashuba and her group looking at Reltegravir levels, again, focusing primarily on women in and around the perimenopausal period and a time when renal function may deteriorate. And the bottom line is Reltegravir levels were fine and there was no evidence of increasing levels with age or with the onset of the menopause. So what about other special populations? I don't really call them special populations. I just think these are situations in which drug-drug interactions are difficult to manage when somebody is receiving a booster, be it cobicistat or being it ritonavir. So that may happen in somebody who requires treatment for tuberculosis, someone who may need chemotherapy, someone who may need an anticoagulant, antidepressant, or treatment for their hepatitis C. And so again, as Pedro alluded to, this may be a situation where you need to make a switch in their antiretroviral drugs in order to allow their second comorbidity condition to be treated much more easily. A lot of the times, these are not absolute contraindications to using these drugs, but it certainly makes it much more challenging. And so by having a drug that does not metabolize through cytochrome P450 just makes management easy. One of the things that I would direct your attention to is, again, this is an app that has been developed by our clinic pharmacists. Extraordinaire. This is unbelievable app. You can download this on your phone or you can access it through our clinic website. It has two lists. On one side, it has hepatitis C and HIV drugs, and you click down all the ones that your patient's on. On the other side, it has any other drug from here to eternity that this person may take, as well as some of the complementary. You click on that side, and then you go push drug interactions, and you get the red light, green light, stop light. So if it's green, everything is good. If it's yellow, there's a caution. And then she tells you why it's a caution. She gives you the reference for why it's a caution, and she tells you what else you can do. Similarly, when the red light comes up, the same thing happens, and is an unbelievable source of information with the references, what to do, and she keeps it up to date after every single conference. So I would recommend you to use this, and it certainly has helped a lot of us, and a very useful tool for those of you who may not have a pharmacist right at hand. Okay, so now it's the younger woman, and this is now the new situation where we need to think about pregnancy choices. So when a young woman comes into the clinic, it's usually, no, I don't want to get pregnant, yes, I do want to get pregnant, or I don't know. And so if they don't want to get pregnant, then of course you may want to have some consideration for oral contraceptives. And there has been an issue over the years about which agents are safest to use in the face of an oral contraception. And again, this is a place where integrase inhibitors are good. They don't metabolize either the estrogen or progesterone, so they work fine. The exception there is, again, if there's a booster. So in Stribild or Gemvoya, because of the cobicistat booster, you're okay with regards to the ethinyl estradiol. Your oral contraceptive will work fine, but progesterone levels go up. And that makes many women nauseous, and they may not be able to tolerate it in that setting. Boosted atazanavir, which has been recommended for women with HIV, it will work fine, but you have to have at least 30 micrograms of ethinyl estradiol in order for the drug to be effective. The other protease inhibitors are not recommended because the oral contraceptive will not be effective under those circumstances, nor will it be with efavirenz, and therefore additional forms of birth control will be necessary. So if she does want to get pregnant, then obviously we want to look at the drugs that are recommended in pregnancy. They have not been updated for a little while and need to be. And I will warn you that these guidelines are way more based on opinion, expert opinion, rather than there being actual data as we have for the antiretroviral guidelines. First of all, the only clinical trial of antiretroviral drugs in pregnancy was AZD. Certainly we don't treat people with AZT anymore, and all of the rest of this is based upon cohort data and data from the pregnancy registry, which is far insufficient for us to know about the safety of drugs in pregnancy. And then the rest of the data comes from animal model, and of course, animal models are largely in rats and rabbits and may not reflect what's going on in the human situation. The other issue is we have changed behavior. So up until very recently, what we used to do is defer antiretroviral therapy until after first trimester of pregnancy to that critical period when the neural tube closes and when much of the organogenesis took place. So we deferred until second trimester of pregnancy. And so most of the data that's in the pregnancy registry are actually women who have been exposed after first trimester. Well, we've changed now, right? So now the way we treat people is we treat them the minute they have HIV. So there's going to be more and more women who are going to become pregnant on antiretroviral drugs. And it's going to be important for us to collect data not only on the new drugs, but also on some of the older drugs, because we're going to have more first trimester exposures. And the big issue is by the time the woman really recognizes she's pregnant, it's usually that 6 or 7 weeks, already, if there's going to be harm done, it's done, and it's too late. So we have to think in advance. So Reltegravir is the integrase inhibitor in the guidelines. That is the one recommended for use in pregnancy. The data to support that decision is rather thin. So I did have one of my fellows several years ago do a systematic review. We identified 278 maternal-infant pairs. There were no consistent fetal or maternal abnormalities. Again, the vast majority of cases were second or third trimester exposures. The French cohort is probably the best data. They have really good data, not only in their HIV-infected patients, but in the general population. So they do have the ability to look at the denominator and see how often this happens. So they have 479 exposures, of a third of them in first trimester. They don't have any neural tube defects. And then the UK and Ireland is the other major cohort. They have about 700 exposures, of which 23% conceived on Reltegravir. They did denote 22 abnormalities, but no neural tube defects. So that's really the data upon which Reltegravir got into the guidelines. Levetagravir is not recommended in pregnancy. And the reason for that is that the cobicistat does not cross well across the placenta, so its levels are low and Levetagravir levels are low. And although we do not have clinical data, there is concern that it will not be effective in preventing maternal-to-child transmission. So this is where the hiccup came, and I know that Margaret discussed this a little bit this morning. I'll just give you a few more details. So this was a study that was started in 2014. This was actually commissioned by the NIH because, as many of you know, efavirenz had a black box warning on it for a lot of years. And the WHO at that point had rolled out ATRIPLA to be the drug of the world, including that of women of childbearing potential. That was based on a lot of meta-analysis in which there was efavirenz exposure in first trimester of pregnancy, suggesting that it was fine. But there was obviously some nilly-wiggly doubt in someone's mind that maybe it wasn't so safe, and that's why this study was commissioned, to make sure it was safe. So this was a study that was evaluating birth outcomes, and its real hypothesis was to say, did efavirenz cause nerve tube defects? So this took place in Botswana, and it's 8 large maternity wards in Botswana that looks after about a half of the births in the country. They have antenatal records for almost every woman. Almost all women deliver in health care and not at home. Very rare for these women to have an abortion. This is a setting of high HIV prevalence, so about 25% of the population is infected, but a very high uptake of antiretrovirals. And prior to the onset of this study, there were many different regimens that were used, with about half of them starting before conception. The study was very well conducted. They trained midwives through a WHO protocol, and when the baby was born, they inspected the baby. If they thought there was an abnormality, they took a picture, and then the picture went to a geneticist to say yay or nay, there was a problem with this baby. So then what happened, the WHO changed their mind, and in 2016, now efavirenz with tenofovir and emtricitabine became the drug of the world for everybody, including pregnant women, and Botswana adapted this change. So how to have your study change in the middle of it. So everybody was on efavirenz, and now everybody is on delegates. And so last year at CROI, they presented interim analysis, and their bottom line was everything's great. There was no difference between efavirenz or delegates in terms of birth outcomes, any fetal abnormalities, anything. And everybody, including myself, went home from CROI last year saying, hey, there's a lot of good data here. There's a lot of women being exposed. We can safely use delegates in first trimester of pregnancy. Whoops. Then when the DSMB had a look at their data, they identified 86 neural tube defects in the first 88,000 births in this cohort, for an incidence rate of 0.1%, which is 9 times that of the national average. The absolute numbers was small. The absolute numbers was 4 out of 500, but the relative risk was high. These neural tubes defects involved all different levels of the neural tube, and of them, 25% were in stillbirths, and of the babies who were born, 40% died within a month. So this is a pretty fatal abnormality if it occurs. So this is just the graph for those of you who prefer graphs, and I think Margaret showed this earlier today. So the neural tube defects by exposure. So the first graph here is deletegravir. There's the point estimate, and there's the confidence intervals. The second bar is anybody receiving something other than dolutegravir. The third arm, those who were receiving efavirenz. The fourth bar, those who started dolutegravir after first trimester. So there's the signal for dolutegravir, 4 out of 426, or 0.9%. They did prove what they set out to prove. There was no problems with efavirenz. There were no neural tube defects there. If dolutegravir was started after first trimester, there was no problem there. And then just to make sure there wasn't a Zika or something going on in the environment, they did a similar thing in the HIV negative population, and as you can see, there was no signal. So the question is, what more are we going to learn? And so what they did is they expanded this cohort to the rest of the centers in Botswana. They estimate they will have another 1,000 or so cases upon which we will be able to generate some information. And then they did some mathematical modeling. Basically, if we end up with 1 more, this is going to be the prevalence. If we end up with 10 more, somehow, Jose, we need you. 10 more, this is going to be the outcome. And as of now, there's been another 500 or so bursts with no more neural tube defects. So the risk right now is about 0.5 or 0.6, so not the 0.9 it was initially. So where does that put you and I? So is this real? Well, it sort of looks real, right? The question is it the drug? And if it is the drug, is it generalizable? Is this something unique to Botswana or something else? In Botswana, they do not use folate on a regular basis. Okay, but then you would have anticipated in the HIV negative group, if that was the cause, it should have shown a single there. But there has been some questions raised as to whether dolutegravir may in fact interfere with the metabolism of folates, and maybe there's some sort of drug interaction there, we don't know. So what more are we going to learn? We're going to learn a little bit more from the rest of this cohort as the rest of the data comes in. In addition, Brazil is trying to look at their cohort because they've had a large number of people enrolled there. But of course, their cohort's going to be contaminated by Zika, which is going to make it difficult to follow. And then there's a site in Africa, in Uganda, where they've had a very large number of exposures, and they're trying to collect information. And then NEAT is trying to get together to collect the cases from North America and Europe to see if we're seeing any cases. But it's really hard for us to know what to tell women in a time of uncertainty. And there are some of the places across the world that the WHO has made this statement, and there are some countries that have said that no woman between 15 and 55 should get dolutegravir. Well, that's a little dramatic, and many of the activists have got up and say, well, this isn't fair. You know, we have the right to choose what drug might be right for us. The other thing we don't know is this a class effect? Dolutegravir and bictegravir are very, very similar in their chemical structure. And so many people are very concerned and do not recommend using bictegravir in this situation either. The question is, I said we don't use levetagravir in this case because we're worried about transmission, so the big question comes back to Reltegravir. And the company is busy trying to get the rest of their data together to give us a little bit more to be able to help us support that decision. The mechanism we don't know. And then the problem is the individual or population approach. For me, it's easy. I can deal with my patients on a one-by-one basis, discuss the risks and benefits, make a plan for that individual woman. But I think in countries where they're having to make population decisions and say all women get this or that, makes it very difficult. I'm going over, am I all right? Okay. And of course, the issues are women often don't plan pregnancies. And this was a study that we had done in Ontario back in 2012, and more than half of our women don't plan their pregnancies. Similarly, the Swiss cohort study conducted between 13 and 14 found that 16% of their women had an unintended pregnancy despite contraception. And in South Africa, a recently published study said 71% of women had an unplanned pregnancy. So having that conversation works for some women, but certainly not for the majority. So the WHO says, well, let's go back to efavirenz. Well, of course, we've all had some concerns about efavirenz, and we cannot underestimate the potential impact that efavirenz may have on a woman's mood. And we know, again, that the postpartum period is a time when depression may happen. This is a study from Malawi, where they were using one of these postnatal depression scale, and found that 1 in 10 of their women on efavirenz likely had some antenatal depression, that although it did not impact their engagement in care, certainly could impact their outcomes. This was another study done by our group in Uganda, looking at the possibility of depression during pregnancy and the postpartum period. The blue line is during pregnancy, the red line is non-pregnant, and the green line is the postpartum. So don't forget that there can be depression during that time. And then the next hook. So this is something called the PHacks SMART study. So this is a study that's being conducted in the United States. And the purpose of this study was to look at in-utero exposure to antiretroviral drugs, really focusing on exposed uninfected children to see what the impact of antiretroviral drugs may have on their health. And this was presented at ID Week 2 weeks ago. So their bottom line is that they were looking for neurologic diagnosis. So anything kind of neurologic they were picking up on. And as you can see, there was a very wide range of things, which included a quarter with microcephaly. They didn't specifically say whether these were neural tube defects, but certainly could be linked in that category. And so what they did is they tried to look at some of the covariates. And of course, many of these studies of exposed uninfected children, particularly in North America, are often confounded by the health status of the woman, often injection drug use, often tobacco use, often homelessness and poverty. And as you can see, all of these factors did come up as covariates for these neurologic conditions, but there was also a trend to more of them happening with time. And then what they did was look at the drug, and lo and behold, the signal once again came out for deletegravir, causing these neurological problems. But again, the number of infants exposed to deletegravir in this cohort was small. So as you can see, although the relative risk was 2, the confidence interval on this is extremely wide because of the low number of cases. But look what number 2 was, efavirenz. So after the WHO says, oh, let's all go back to efavirenz, this study now is showing a signal for efavirenz and causing some of these neurologic abnormalities in this study as well. And then they ran a whole bunch of different sensitivity analysis looking at some of the other confounders. And again, both deletegravir and efavirenz have maintained this signal on a multivariate model. So they did find a large number of these neurologic cases. There seemed to be these association with the drug, but again, this is an association and not a causation, but unfortunately is adding fuel to the fire as we're trying to make these decisions for our women. So what else are we going to do? So it sounds, at the moment, many of us are looking at Reltegravir, hoping that that signal will not be a class effect, but otherwise going back to the protease inhibitors, which of course have their own tolerability issues, and particularly if a woman's pregnant, to put her on a boosted protease inhibitor sometimes is associated with a lot of GI side effects. We now have the new single tablet formulation with darunavir boosted by cobicistat together with TAF. But just like the problem with Levetagravir, when you give darunavir boosted by cobicistat, again, the cobicistat does not cross the placenta and darunavir levels are too low, so that's not an option either. So, on that happy note, I am going to close there and say that, yes, integrase inhibitors are now the recommended therapy in all guidelines. They are an excellent choice in special populations, particularly with regards to drug-drug interactions. They're a good choice with aging to stop the additive risk of metabolic and organ dysfunction. But for women, particularly those of childbearing potential, we really need to talk about this with our women on an individual basis to make some decisions with respect to potential fetal exposure. So I thank you.